very famous glaucoma specialists from all over the world to give some of their knowledge to the future generation of ophthalmologists and glaucoma specialists. They are highly skilled, and I want to thank all of them who they respond very quickly to my invitation. And also I want to thank Amman pharmaceutical industry who support a lot of our activity in the Royal Medical Services and in Jordan, and support these virtual conferences, especially Dr. Fadi Al-Atrash. He will talk 5 to 10 minutes about his company and the medication he support the glaucoma field. Please, Dr. Fadi, and we will start after that with Dr. Ahmed Akman, because we won't be late for him in order he can join the other meeting which was planned before. Go ahead, Dr. Fadi.
Thank you, Dr. Mohannad, for the introduction. And I want to welcome everyone, Dr. Pinto from Portugal, Dr. Ahmed from Turkey, and Dr. Salman from Belgium, and Dr. Arif from the US. It's a great honor to be with you today. I just want to give a quick presentation about our company, just for you to get more familiar with it. So Amman pharmaceutical industry, you know, the capital of Jordan is Amman. So when we thought about the name of the company, we said, you know, we will call it upon our beloved capital. For those who are not familiar with the Kingdom of Jordan, the population is around 10 million. We have a GDP almost 89 billion. The industry sector makes around 30% of the GDP, where we are fit here as the medical or the pharma industry. Our mission is to provide patients worldwide with quality products that are affordable and most effective, while maintaining high levels of production excellence. Our vision is to become the regional market leader, especially in niche differentiated products, for example, the ophthalmology. And by the way, we are one of the few companies in the Middle East and North Africa that are specialized in this kind of dosage form. Our journey, it began in 1989. Actually, it was my dad who established this. It's a family business. So my dad, he established this business back in 1989. In 1992, we penetrated the Saudi market. 1999, we started the second expansion. 2005, we had a new era in the management of the company. 2012, we were nominated as one of the best companies here in Jordan by the Ernst & Young institution. In 2018, we introduced our 7th line, and now we have switched to green energy, where most of our electricity is being generated by photovoltaic cells. The factory, as total space, is around 5,000 meters square. We have 10,000 meters square dedicated for warehouses, 500 for laboratory, and we have 7 production lines, which are the sterile eye drops, sterile eye ointment, non-sterile ear and nose, topical dermatology, oral preparation, nasal meter dose sprays, and bag on valve. Our accreditations, we have the accreditations from the WHO, from the Red Cross, the ICRC, from all the countries where we export our products to, and we got a recognition, a local recognition here from Endeavor and from Ernst & Young. Our products are, first of all, the sterile eye drops, which is almost 33% of our revenues comes from these products. Some of them, of course, they are anti-glaucoma products. We have the sterile eye ointments. We have the nasal sprays. We have the non-sterile drops. We have the topical dermatology products. We have oral preparations. And finally, this new line, which we introduced last year, it's I'm sure that you are familiar with the seawater. So this is like a nasal jet spray coming actually from the Dead Sea here in Jordan. And we have some in-licensed product like, you know, the hyaluronic acid and other ophthalmology product like the cyclosporine for natural tears or as a lubricant. Our markets, we are in Africa, in Angola, Ethiopia, Kenya, Tanzania, Uganda, Congo, Eritrea, Somalia, and South Sudan. We are in the MENA region. We are in the CIS country like Uzbekistan, Azerbaijan, and Kazakhstan. This is our organization structure. We have, of course, an independent board of directors, and this is the whole organization structure of our company. And this is just like some pictures from our state-of-art production facilities, which complies with the European GMP, the good manufacturing practice of Europe. Thank you, and welcome again to this valuable webinar. And thank you, Dr. Muhannad.
Thank you, Dr. Fadi. Thank you for this short summary about this great company in Jordan and in the region. And we hope that prosperity and progress to your company and your hope and vision will be accomplished in the very near.
Thank you very much. Thank you.
Thank you very much. And now we'll start our scientific agenda. Any from the panelists have a question to Dr. Fadi Al-Atrash about his company? If you want. So no access to USA market now. Fadi,
not yet. Not yet. Actually, we were planning this year to have some FDA inspectors actually from the US, because in order for you to export to the US market, you need the FDA approval. But because of the Corona crisis, everything is postponed.
Turkey, Belgium, not yet. Not of
in Europe, we have the European GMP. We have started actually in Malta. Don't ask me why, but we started with this small country, and actually from there we are planning to to go up north to Western and Eastern Europe.
Great. Thank you very much.
Thank you, Dr.
And now we will start our scientific agenda, and we will start by our great professor, Dr. Ahmed Akman from Turkey. And as you all know, he has been working in Ankara Başkent University for a long time ago. And he was, since it's the establishment of the ophthalmology department, he was there and head the glaucoma division there. And he earned his glaucoma training at Duke University in North Carolina, USA. Dr. Ahmed is also, he published more than 250 articles, and he has also a very famous book, which is taught by all residents now. I gave them a copy, and they have to understand every letter in it. It is the OCT in a glaucoma patient. And we are very happy to join us, Dr. Ahmed. And his talk will be about the medical management or update in medical management of glaucoma before we convert to surgery to other speakers. Please, Dr. Ahmed, the mic is yours.
Thank you for this invitation and having with this great group of glaucoma people. And thank you, Mohammed, for your great words. I hope it will be a very nice meeting. I'm starting to share my screen now. And let's see if everything goes okay.
Yeah, great.
Okay.
Yeah.
I will talk on update on medical management of glaucoma now. For last 25 years, actually, we are on a standard treatment, like start of the myotics in 19th century. Then we had the sympathomimetics, carbonic anhydrase inhibitors. And at time of my residency, we had the pilocarpine and timolol. Then we start to have the topical carbonic anhydrase inhibitors. Later, the prostaglandin analogs became available. And with the 1991, we don't have a lot of different group of medications till today. But what we learned during last 25 years, the ocular hypertension treatment study and other studies showed us not every ocular hypertensive progressed to the glaucoma. OCT revolution changed our glaucoma management. We have the OCT in our hand, and OCT progression analysis gives us to see who is progressing in very, very early stages. We now have better visual field algorithms, which simplified visual field testing. And we now have better understanding what structure and function relation is in glaucoma. Also, we learned that preservatives cause significant problems with long-term exposure, and patient compliance with multi-drop regimens is a real issue. EGS guidelines gives us a standard. Surgical indications changed a lot, more surgery for drug intolerant patients now, and we still need better drugs with fewer side effects. Also, we know that still lasers are not very effective and first-line treatment in most of our patients. We wish we had better results with the lasers. Number of ophthalmologists doing glaucoma surgery is decreasing mostly in US and probably in the rest of the world. And mixed revolution may change the way we treat glaucoma in the coming years. Actually, we have a glaucoma treatment paradox. We have many highly effective and proven molecules that can lower IOP, but many patients either can't, won't, or don't use their drops as prescribed. We need to find novel ways to deliver these molecules to the eyes independent of patient response. These are the EGS guidelines. I will not go over them in detail. We all know that they are the great foundation of our treatment principles. We have these algorithms to see which will be the first choice of the treatment. And with this, we can have personalized treatment protocols for each patient. Generally, we start with prostaglandin analogs and beta blockers as first-line treatments and add the others as combination or second-line treatments. And we try to look what are the systemic contraindications in each patient to choose the best personalized treatment for him. So, when we go over the EGS guidelines, we choose who to treat. We set a target IOP, we start with monotherapy, use combinations if necessary, add second drop if necessary, and follow up progression to check side effects. My personal approach is choose who to treat at first. So OCT and OCT progression analysis for ocular hypertensives and preparametric glaucoma patients, and OCT progression analysis and visual field for parametric glaucoma patients. Then I target the IOP with the help of the OCT progression analysis and to see that if the treatment I'm giving to the patient is preventing the progression, and try to set the target IOP with these results. Then start with monotherapy and try to avoid benzalkonium chloride. PGAs are my first choice if bilateral. Sometimes PGA and beta blockers, because they, although not very much more effective, they have less hyperemia. For the single eye treatment, beta blocker or fixed combinations are better in my hands. And alpha mimetics are my first choices for normal tension glaucoma patients. So this is what we are doing for the last maybe 22 years with the standard class of medications that we have. So what is new in these days? We go for the preservative-free options. We have new combinations, we have new glaucoma drops, and we have new drug delivery systems. For the preserved eye drops for glaucoma, they are available for nearly more than 100 years. They are effective and cheap. Compliance is the biggest issue. They are difficult to administer. People forget to use them, forget to refill them. They have unpleasant side effects. And I think in maybe not 2 years, 5 years, but in the future, they will disappear. Currently, there are new topical delivery systems becoming available, preservative-free single dose, preservative-free multi-dose drops, and sustained release systems like fornix implants, intracanalicular inserts, contact lenses, and long-acting gels. Preservatives are a big problem for us. At first, for the surface, they cause ocular surface damage, apoptosis, free radical generation, goblet cell damage, inflammation, cytokines, dry eyes, and unstable tear films. we see a lot of corneal problems with them and conjunctival problems with them. Also, there are some studies from Christopher Bedo in trabecular meshwork damage from the preservatives also, that in the long term can result with IOP increase. That may be the reason for the loss of effectiveness of glaucoma drops in long time. And every patient deserves, I think, bug-free alternatives if they are intolerant to them. The single dose ones are not new, but still not very common. Cost can be a problem. It's a problem in Turkey. The government don't pay extra money for the single use ones, so companies are not bringing them to the market. They may increase patient compliance. The good thing is patients are very familiar to them from artificial tears, but they can a little bit difficult to use for the elderly people. They are currently available in many countries. This is one of my patients. He was on Bimatoprost in one eye, and there are a lot of dye on the cornea. When I use single dose Traveprost on his other eye, it's much my But unfortunately, Traveprost is not still available in Turkey because of the cost. So some of my friends are, my patients are trying to find or buy them from the Greek islands, which are very near to Turkey. Now we are in a time that new glaucoma medications are becoming available. We are waiting Vyzulta in Turkey in a few months, hopefully not postponed because of the pandemic. And Rhopressa, I think it will not be available in Turkey in few years, but hope to see it in market also. Vyzulta was approved from FDA, I think in 2017, if I'm not mistaken, for primary open-angle glaucoma and ocular hypertension. It has a dual mechanism of action. The latanoprost increases avascular outflow, which we are using it for 20 years, but it also has a part breaks down into nitric oxide, and nitric oxide increases outflow through the trabecular meshwork and the Schlemm canal. In phase 3 studies, Vyzulta demonstrated a mean reduction of around 8 to 9 millimeters mercury from the baseline. It's used for once a day. Its side effects were similar to those associated with other prostaglandin analogs. We start to have multi-drug combinations available in Turkey, like Simbrinza. So it's a new area for us. While waiting for Vyzulta, we are using them. Compliance and preservative advantage and additivity is important for combinations. In US, there are compounding companies. They can put 2, 3, 4 molecules in a single bottle, but it's not available in my country. But currently, with a PGA and beta blocker combination in one bottle and Simbrinza carbonic anhydrase inhibitor and alpha agonist in the second bottle, we can have 4 molecules in 3 drops in 2 bottles. Sorry, now. Then we have the Rhopressa. It's Netarsudil. It's again FDA approved in 1997 for primary open-angle glaucoma and ocular hypertension treatment. It's a Rho kinase inhibitor. It lowers IOP through 3 mechanisms of action, increasing outflow via trabecular meshwork, decreasing production of aqueous humor, and decreasing epicellular venous pressure. You have to show non-inferiority to timolol to have the FDA approval, and it shows that. It's again once daily. It reduces IOP around 4 millimeters mercury. It may decrease IOP in patients with low IOPs. It can be an important factor while using it as a second-line drug. Conjunctival hyperemia was the most common side effect, and it has a combination also with latanoprost called Roclatan. And these are the drops, new drops we have in the market. Then we have the topical sustained release systems, which I think a great idea, but still not on the market. Bimatoprost ring. It's a large silicone ring, fits in the fornix, available in different diameters. It's well tolerated, and the only thing patient feels is the increased mucus production. It can lower IOP nearly 20% around 6 months, and there is some debate about the continuous dosing of prostaglandin analogs may be less effective. We will see if it is going to be available on the market. But the early studies showed quite good results. Also, some other companies are working on intracanalicular Travoprost implants. It can be inserted into the lower canalicles like a punctal plug. It was in phase 3 trials. It reduced IOP 24% on day 10 and 15% at the day of 30. Only 40% of the plugs still retained in 30th day, but we will see if it will be available on the market. It's more practical and safe than the intracameral implants. Now, this is something became available on US market recently. We have the anterior chamber implants. It's from Allergan, the novel system the first novel system reached to the market. It's an anterior chamber biodegradable implant. It shows 30% IOP lowering for 4+ months, maybe for 6 months. Its commercial name is Durista, and FDA approved it just 2 months ago. Maybe Dr. Aref has some experience with them, and also for Rhopressa and Vyzulta, he can give us some experience from those. Durista reduced IOP approximately 30% from baseline over 12-week efficiency period. Also, some other anterior chamber implants from different companies will be probably available in near future, like the ocular therapeutics one with the Travoprost, which has the fluorescein dye in it to better visualization of the implant, or iDose Travoprost, which can be from Glaukos, a titanium implant carrier for Travoprost. It has favorable results in phase 2, must be changed every 6 months, and it's anchored to the sclera for easy removal. Also, there are a lot of research going on, which are, most of them are preclinical, but long-acting gels, surface implants, subconjunctival implants, sustained-released injectables, or like scleral implants. But the problem is, will patients accept these novel systems? I try to ask my patients, will you accept an intraocular anterior chamber injection instead of eye drops? And they're a little bit afraid of it. Maybe it becomes more common and people will accept it more, but most of them says, no, I will go with my drops at the moment. And this is all I can say. I hope this nightmare is over, and I want to invite all of you to my country to see Göreme area and have a balloon flight there. Thank you.
Thank you, Dr. Ahmed, for this nice presentation and make us updated with the new medical treatment in glaucoma. If Dr. Aref has some comment on the new drug in United States, and are they available, and do the patient accept them, or what are the indication of new medication or new devices to be put on intraocular for control of intraocular pressure?
Yeah, thank you very much. That was really a great comprehensive talk, Dr. Akman. I really enjoyed that.
Thank you.
You know, it's interesting, the Bimatoprost implant was just FDA approved just a few weeks before the COVID pandemic. And the FDA indication has only approved it for one-time use, not repeated use. So, you know, many in the US, including myself, have not had a chance to use it, but once it does become available in the next few weeks, we have to think carefully about who would be a candidate for the injection, because we're only FDA approved to use it once. And so it's a very interesting indication, and maybe that will change with time. So I don't have direct experience with that one. With Rhopressa and Notarsidil, it's a fantastic medication, I think. Notarsidil can be combined with latanoprost as Rocklatan. And so I think it's a very effective treatment regimen when we combine Rocklatan with another combination agent such as Simbrinza or dorzolamide timolol. It's a very effective way to treat our patients with minimizing the number of treatment bottles. As you alluded to, Dr. Akman, Rhopressa tends to be effective for patients with lower intraocular pressures. And those are the patients we have the most difficult time with getting incremental lowering. Those patients who have pressures maybe in the high teens that need just a few more points lower for the long term, Rhopressa can be effective because of the mechanism of action in which it lowers episclerovenous pressure. So it's been a very effective agent for us. Some patients get tremendous responses. You know, we've seen younger patients in particular get, you know, a 10-point millimeter mercury drop from just Rhopressa. And, you know, some patients don't respond as well. So we're still learning about who is predicted to be a good responder and not, but hopefully it'll become more widely available, and it's been a very useful drug for us.
Okay, because you know that the tolerance and compliance of the patient is the major obstacles we find in glaucoma patient. And many patients who did not tolerate or compliant with their medication, I already go for surgery. So I think these long-standing or long-release anti-glaucoma medication, they will be a revolution in the glaucoma management. But you said that it can be once a time can be used, so we cannot repeat after 4 months. We not put another device in the anterior chamber, or what?
Yeah, currently that's the way that it's FDA approved, believe it or not. And so, you know, hopefully that will change. And, you know, I agree with you, Dr. Muhannad, that it will revolutionize our glaucoma treatment, but it's going to take a little bit of time. Even if we were able to repeat dosing with Durysta, remember, you know, latanoprost and Bimatoprost, those are one-time daily medications. And usually patients, of all the medications that we treat our patients with, those are the prostaglandin analogs are the ones that are most easily tolerated and easily used. So I think the major revolution will happen once we have combination agents that can be injected safely. And we're probably still, you know, a few years away from that, but I think it's a start. You know, this is a start, and it's definitely effective, as you pointed out, Dr. Akman, with the clinical trials. The injection form of Bimatoprost is just as effective, if not more, than topical Bimatoprost, whereas with the other sustained release therapies, there's a trade-off. Those are not as effective as eye drops. So I think time will tell.
Okay. Dr. Akman, there is a question about when do you switch from one prostaglandin to another? So if the latanoprost does not achieve the target pressure, will you switch to Bimatoprost or Tafloprost, or you switch all the prostaglandin?
I generally don't switch to prostaglandins because of the results that I have. But we have the Tafloprost without benzalkonium chloride, BAK, in Turkey. So that's the most of the reason I change a prostaglandin from the other companies to the Travoprost, because I don't want to have benzalkonium chloride usage in the eye drops. But the EGS guidelines tell you can change it. But my experience is the prostaglandin ineffectiveness is not very common, I think. And I generally add a second molecule to the patient if he is not on the target IOP with a single prostaglandin. I don't change because of the IOP level. I'm not sure what the others think about it.
Yes, well, Dr. Prof. Pinto, do you think that a switch from one prostaglandin to another is you can change or not?
There are data that supports that at least 1/3 of patients that are non-responders to latanoprost might be good responders to another, namely the paper that exists is on Bimatoprost. The reason is, why are you changing it? Is it because intolerance, it might be the same, and if you just want to have lower targets, then you might not consider, I mean, there's a theoretical benefit on 1/3 of patients, but probably you will consider some other drugs, most likely. That was your question, if I would change one for the other, I think.
Yeah, okay. There's another question from Adib. Adib, go ahead and you can ask your question directly to the panelists.
I think his microphone is.
Yeah, you can. Yeah, you can ask now.
Implant last.
Can you repeat, Adib? Can you repeat your question, because the mic was muted?
How long does the effect of the implant last?
Probably from the data, 4+ months, 4 to 6 months. They tell.
Yeah.
Okay, but do you think the patients will agree for the a second implant?
Let's say it's working for 6 months. That's the question. Do you think even for yourself, you go for the eye drops or intraocular injection every 6 months? I'm not sure. Yeah, people are afraid of having needles in their eyes.
Yeah, that is true. Thank you.
Thank you.
In Europe?
Yeah. Thank you.
Sir?
Dr. Ingeborg, do you hear us?
Yes, I do hear you. Yes.
Yeah.
Yes.
Do you have these long-standing anti-glaucoma medication in Europe or not yet?
No, we don't have them available yet. We did participate in the studies, so we have some experience because of that, and so we have also experienced the threshold for the patients. So I have been talking to a lot of patients about the possibility, and indeed there is quite a bit of resistance to have these injections in the eye. Although if you think about AMD, very regular injections are used there as well, and it is well accepted. However, I feel here the difference is that when you can't effectively treat AMD with drops, and the injections actually improve their vision. So that is a different type of motivation, obviously. So I think the barriers will be there. The acceptance might improve in the future, but certainly to make it feasible as a treatment, obviously repeat injections would be needed. I don't see the sense of approving a single injection. It's a bit awkward.
Yeah, you are right. Thank you very much. Thank you, Dr. Ahmed. Yeah, go ahead, Prof. Lois.
I was just going to say that, in the continuation of what Professor Stallmans was saying, I think that the problem is this only replaces one drop. So the patient that comes in that's only one drop is probably a mild glaucoma. And so if he's controlled under one drop, he might be unwilling to have an injection. But if he's on for 3 or 4 drops, and if we offer him an injection that is worth 3 or 4 drops, then we will probably see the patient saying, I would rather do an injection every 6 months than having to put 4 or 5 drops per day. But then we have to offer him something that is far more effective than what we were able to offer him right now.
Yeah, very good.
Okay. Yeah, thank you very much. Thank you, Dr. Ahmed Akman, for this nice presentation and covering the update in medical management. And now we are going to the next speaker, Dr. Lewis Pinto, and he's gonna talk about the new innovation in glaucoma surgery. Dr. Lewis Pinto, he is the head of glaucoma clinic at Department of Ophthalmology in Portugal, which is the largest hospital, and he served as the professor of ophthalmology in Lisbon University. Dr. Pinto, the mic is yours, please.
Oh, thank you for the invitation. This is actually a very provocative title. It's going to be a very fun discussion afterwards, I'm pretty sure. So the discussion was, and this has been put into context by Professor Hakmet, is that we're overwhelmed with patients that we can either offer them drops or surgery. There's quite a few patients in our clinics, and as the EGS guidelines will tell you, we would first try always or almost immediately with medical treatment or even laser. So this would be the to-go options that we faced with our primary open-angle glaucoma patients as they come in through our doors. The problem is there's so many of them, and this is a paper from my reality, is that if you consider 2 or 3% of the population putting drops, in my population, my setting, that's over 200,000 people putting drops. And if we go over the lists, it means that at least 20% around are putting 3 or 4 classes. So if they all come in for surgery, I mean, 20% of 200,000, that's 40,000 surgeries that would have been needed. And that's already too much for what we could do. Particularly because compliance is an issue. If we agree that these patients need to be on the 3 classes, well, a lot of them are putting 3 or 4 drops already. So 1/3 of them will be putting 3 or more drops. And as I can't ask a patient to remind himself to put this many drops per day and expect full compliance. I mean, I would probably not have remembered them myself. And probably if it feels like this, these are pictures from my patients. So obviously, even from aesthetic reasons or just allergies or atopes, you would not want to be going over like this for the rest of your life, because treatment will be, of course, chronic. Because it is difficult to keep them on that target pressure we want, especially with the side effects and compliance issues. If we want to define target IOP and we really want the patient to be on that low level, probably we need to consider other options than just medical treatment. And this is what the title comes into effect. The trabeculectomy has been published to be the most widely performed technique. It's very difficult to have a complication that has never been described. And so I mean, there's no unseen complications. We know the long-term data. We've been performing it for 40 years, upgrading, learning from our mistakes, patient profiling. And so the reason for something that exists over 40 years is that it works. Otherwise, we would have found a replacement already. So if it was easy to beat, it would have been beaten already. This is a paper that we mostly see when we talk about trabeculectomies, is that the surgery to beat actually offers a very good success rate, and which would most likely put your patient into mid-teens. The discussion, of course, is whether or not that patient that's just allergic to everything, does he need to be on the low teens? Or is he able to come back to that number of consultations that need to be done when you need this? So it is a lot of work for both us and the patients, and most of our patients would be in their 80s or sometimes over about nearly 90s. And you would consider if you want to ask them to come 3 or 4 times within the first months. And it's certainly not without risks. I mean, how many times have you come with a trab and then 3 weeks after you say to a patient, this is not going well, we need to do a needling or a bleb revision, or even have to say to them that, okay, this didn't work and we need to do something else. So even if it is very good, it's not foolproof. So the question is, does this surgery that we know it works, we know it's very effective, it's been around for a lot of time, is it still the gold standard? So if you ask, this would be Ronaldo. Remember, I'm Portuguese. So this is a very good player that's been the top player for the last 10 years. And is he still the best player in the world? That would be the question. Or are we in a rush to replace him? Well, apparently we are, because there is an increase in surgical trends. I mean, even though filtering surgery numbers are going down, the number of non-invasive procedures in our toolbox is increasing. So we're trying to run away from these surgeries that have a steep learning curve, that are very surgeon dependent, like a cookbook. I mean, I will do it this way. My colleague would make a slight twitch. And so it's very difficult to predict how the two surgeons would do, even if they're in two different rooms in the same building. And so there is a trend towards surgeons wanting to move away from that player, so to speak. This is a paper from the American Glaucoma Society, where if you ask, and this is questions that they make every 6 years, and you will see that the recent inquiries already suggest that a significant number of surgeons are willing to do something like a MIGS on their, even as a standalone procedure, on their patients. That number would further increase if you would ask him if it's combined procedure. And I'm pretty sure that Professor Arif will speak about this as an option. But so with the upcoming trends, and every year there's new players coming in, and everyone is betting whether their careers would be as great as the other ones. And there are quite a new surgeries coming in. And remember that 10 years ago, we were discussing whether it was trabs or non-penetrating surgeries. Now the discussion is far more complex. So I will be discussing XENS, UCP, and tube surgery. Professor Stallmans will be speaking about Preserflow, and Professor Arif, if I am not mistaken, will be speaking about Cahook and iStent. So about the Cicloplasty, so the UCP, it's a non-invasive surgery in the sense that you don't have to make an incision. It's based on ultrasound. So when you think about cyclodestructive procedures, you always think about that neovascular, painful eye that the patient just wants to get rid of the pain, and you're just trying to offer him something that at least won't take him to the surgery stitching involving. So what this does is uses ultrasound, and this has been used everywhere in medicine, not just ophthalmology, like a focused ultrasound to make sure that it only heats a certain target, not the whole tissue, and it allows them to precisely and pinpoint a small burning. So it's a much more controlled environment, and you actually know how much it's being heated. So what it does, the probe, is that you put it close to the eye, or you attach it to the eye, and it will burn 6. I'm not sure if you're seeing the mouse. You will see those 6 dots or 6 circles being burned, and they will be coagulating the very pinpoint area that you decided to pinpoint to do. So if you do an ab intern, or if you do this on a monkey and then you sacrifice the eye, you will see the difference between those laser-based cyclo, where we have to have a very good experience to hear the pop, and what you see here on the top image is the result of those pop. It's the unpredictability and the experience that it needs to be had by the surgeon, or to have the machine done it by you, and on a hypobaric procedure. So it's a much less surgeon-dependent technique. You just have to screen the patient well, but within the OR, the number of tricks is not as high as you would have had with a laser. So if you have, and this is also done with endoscopic imaging, you will see this is a technique being done, and there's no popping. It's actually very calm, and you just see the ciliary processes being hidden, and that's done. So there's no big inflammation and no explosions that would have occurred. So actually, this is a very straightforward procedure. So actually, the learning curve is very, very low. 6 would do to get the company to certify you. And it takes around 2-3 minutes once you start the procedure. To give you the impression, the first time we had the machine in my department, we did 11, I think it was 11 in 4 hours. So I mean, even with all the learning curve, the first time we were able to do the circuits to make this work, because this was not exactly hard. So you just have to, you don't even use a speculum, you just have to put the probe, and then you apply the device. You just press a pedal. It needs to be centered. There are a few tricks into this, but it's not as complex as doing actually incisional surgery. We were part together with other centers, including Belgium, on a clinical trial to see whether or not these theoretical advantages could be used on those patients that actually could see. So shifting from the paradigm of doing this only on blind eyes or painful eyes, whether eyes that were seeing, functioning, naive surgery, would they be suitable candidates to have this? And actually, in opposition to what we were saying, if you tell the patient, I am not going to do a cut in your eye, let me try this first. Actually, patients are very good responders to this type of message, because as Professor Ackman was telling, people do not like to have scissors or cuts. So the message of not incisional, it's actually something that patients respond actually very well. So we had 117 patients followed for, the outcome was 2 years. And as you would see, that we would have a relatively young population that were, I mean, considering we know that it decreases around 20 to 30%, the preoperative was low 20s. And you would see that the baseline and the results would put the responder rate up to 3/4, which means that if you offer this solution to 4 patients, 3 of them would have around a 30% reduction. So basically bringing them from low 20s to a very good response under the same type of drops. So if you then screen to the ones who are responders, so if you could actually pinpoint which of these 3 would actually respond, and you don't offer it to the one that doesn't respond, then you're actually more comfortable to say to the patient, there's a very good chance to put you on the very low teens. Most likely, we could probably take a drop out of you if we don't need to have those very low teens. And especially if you're considering POAGs and not exfoliative, which are a bit more tricky, then those responder rates goes actually much better. The safety profile is actually, if you've done it once and you compare it to a regular laser cycle destruction, the safety profile is actually very good. I mean, you're used to having the patients coming on day 1 with the laser complaining, and you saying, you have to trust me. I know you were better off the day before, but you have to trust me that this is for your own good. You don't have to do this with the UCP. So the patient will say, yes, I feel something, but it will be a conversation as a feel. So he would not be completely, under painkillers. And we had a very low complication rate of serious sight-threatening complications, which was very good, considering that these were seeing eyes. So, and because it's a critique with every one which is clinical trials always perform very well. What about clinical practice? Because you're not screening for criteria, you're just doing whatever feels right from your clinical point of view. So what we've done is we screened the ones that were not included in the trial. And actually the results were more or less what we would expect. So success rate was around 70%, so a little bit less, which would be expected. And actually, because we offered it already with patients that were a little bit higher in IOPs, the reduction rate was more or less the same. So with 30% reduction to the high teens. So basically keeping them after filtering surgery. From the safety point of view, what you would, if you have experience with UCP, 2 things come to mind. Patients might complain during the first months that they have a change in vision, and that probably relates to those tricks that you probably would have to do in the OR. These are three images of, from the left to right, extremely well centered, medium centered, and poor centration. So if you don't apply the pressure and the UCP to the proper place, then of course you might be burning some things that you don't want to burn, and you might change your astigmatism because the corneal surface might suffer. So if you probably are having too much of an astigmatism afterwards, you probably have to think twice if you're centering it well, because the astigmatism induction on the ones who are very good centered is actually under 1 diopter. The other thing you will have noticed is that the pupil might be a little bit higher, and that's because probably the heats and the ciliary muscle that probably takes a hit during the first months, and you will see that the pupil becomes a little bit bigger. But then with time, and this is pictures from the same patients from the clinical trial, you will see that it comes relatively back to normal on the logarithmic point of view. So actually, we could not detect anything that could have predicted who would have get that small mydriasis. But so it's not something that you could not have guessed. So it's not a screening problem. And we still don't know exactly who or why it does that. We do know, however, that the typical UCP patient is an elderly patient with a moderate stage pseudophakic triple therapy and IOP in the mid-20s, because the rationale is, if I'm aiming at high teens, then I can't start with 40. So because if I start with 40, I will not be happy. So I have to give reasonable expectations to both the patient and myself, which is, if I have a target in the high teens, I have several options. I can either use this to take 1 drop off, or I could keep them on the same drops and just give them a better safety profile. And the fact that I don't have to do this, I don't have to take them back to the OR, there's no needling, it's predictable as long as you're a responder, and you can do it again if needed. There are already documentations on this. So basically, the company itself, and I think I agree, that it's putting the UCP not only on the severe case on the need of diode, but actually pushing it away closer to the patients who want to push the filtering surgery as far down the road and kick the can as much as they can. So moving away from UCP, and because time is short, I would move for the XEN, which is something that most of you will already have heard. There are experience now with over 60,000 XENs used worldwide. It is a mix, although agreeable that the title can be changed or discussed, but we can still think of it as a minimal invasive glaucoma surgery. It has a design that will cause a resistance to flow, according to Poiseuille's law, around to 6 millimeters of mercury, which means that this is a video that that uses a gonio. I personally don't, but I thought this was very well centered. That you actually use probably one of the side ports from the fake, or just do an incisional afterwards, and you just go in with the injector, and you just find the place you want with the gonio lens or without. This is a discussion we can have afterwards, and you just flick it in. So you can then see the bled forming, but it's actually a very smooth procedure. So again, you can tell the patient, especially if it's after phaco, that you will most likely at the end try to implant a stent to try to minimize the burden of the drops. The data on this comes from a very large trial, which is called the APEX study, which was a prospective multicentric 2-year study with inclusion criteria with mild to moderate glaucoma patients that could be from 1 to 4 drops with 18 to 33 millimeters. And actually you can see that with a very large number, with intention to treat over 200 eyes, you will see that the average patient would have been with 16 millimeters of mercury with 1 drop. So when you're doing this, you have to think, would that satisfy me? So if you have a very, very advanced case, then probably XEN will not let you get there. Although the vast majority of our patients is not exactly a 0.95 cupping, well, depending on what you work, but let's imagine the basis of the triangle will inevitably have mild to moderate cases. So this would suit those cases that are actually the majority of the patients where these targets would actually work very well. And this apparently, this is something that's also very interesting, the results from the XEN and the phaco-XEN are actually very, very well overlapping, which means that probably the inflammation due to the XEN is very limited compared to the phaco itself. So can we improve from this? I mean, 16 millimeters, because again, real life is not a clinical trial. A lot of these people doing this trial were very experienced surgeons that were very keen to have good results. They were monitored, they were not masked. So how does this come up with real life? I mean, if I start to do a XEN, will it work this way? You have to learn a few tricks. This is a little bit more complex than the UCP. And because of that, there have been recommendations on how to prepare, how to assess, and how to manage your post-op. Because you don't want to start, I mean, if there are literature, if there are things that come from here, you should learn from the mistakes of others. And you can't live long enough to make them all yourself. So you better learn from someone else. So basically what we need would be to read all those recommendations. There are quite a few, but they all focus on one thing: minimize bleeding, lower conjunctival resistance, and then control the inflammations afterwards. Just to give you a hint, if you're planning to start on XEN, if you have low experience, this is something that you can get certified as well with 6 implants. And this to give you a paper we've done where we compare residents doing their first 6 cases with specialists comparing their 6 cases. And actually after the first 6, you will see that the number actually of complications were fairly similar. And the amount of time actually on the OR, especially if the residents already have a phaco experience, so I can imagine that a general ophthalmologist with a phaco experience, you will see that from the number of minutes that come here, from table 2 and 3, will give you how much time it took from the first XEN, and you will see that it takes an average half an hour, depending on if you're a resident or a specialist, and can easily done from below 20 minutes. So you gain 10 minutes out of the first 2 or 3rd XENs. So it's a very fast learning curve, either with a phaco or with a XEN. Number of complications actually, probably because this is a non-mask, specialists got a little bit more complication than the residents. You could take that from that working on a safe environment with someone else selecting patients for you, it's actually a very safe technique. This is something that's for discussion. You're always afraid, where do I implant him? I don't want to do a gonio. What happens if I do this anterior or posterior? And what happens if I just pierce it on the wrong place? This is a study that just got accepted this week from publication on Journal of Glaucoma from us, which is, we pictured all the XENs we did, and we did around 200 of them. And we went to see if the location that it ended up with had anything to do with the success rate or complications. Because we don't use a gonio lens, and there's no difference. So if you don't want to use a gonio lens, or if you're too worried that it got a little bit higher or a little bit lower, it does not make that much of a difference. Because probably what will make it fail or not will be the conjunctiva at the end, and not exactly worrying yourself to death whether or not is it a little bit higher or a little bit lower. So your patient selection needs to focus on the conjunctiva most likely, because the success rates are basically similar regardless of whether you put it a little bit higher or worse. So no need to reposition it as long as you think it's well stuck and it won't actually, I mean, it's not completely outside of the box. So as again, if you have to select a patient, consider that you want to have the 16 with 1 drop, and whether or not that suits your patient. Most likely needs to be a non-progressive patient. or otherwise a patient that was progressing under 24 and 16 sounds a very good plan, and you don't want, but I would strongly suggest to use XENs instead of a trab on an advanced case. So do not, if you use this instead of a trab on a patient that has 0.95 and you were hoping to get 10, then you need to be realistic to that patient and saying, okay, XEN is very good for the big chunk of the pyramid, probably not the top. Unless, of course, on special circumstances. And this is why I got this expanding with new horizons, because although it's meant for the larger part of the pie chart, on certain occasions, and this is why they're exploring it, on special cases of controlled uveitis or special cases, not having to do an incision on the conjunctiva might actually be a good niche, but it needs to be very well discussed, and we don't have time. So to summarize the last part, or to finish, I would talk about tubes. The ones on the left, the classic ones, are the Hamid and the Barvold, and those would be the ones most widely spread. But there are three new kids on the block. There's the Pole, the ClearPath, or the Barvold XEN, which I will explain later. And to sum up, I will just talk about these two. Why is it a big rush on tubes? Well, basically because we don't like our classic choices. We're always complaining that, oh, I'm very happy with my Barvolds. That's just because I learned to live with going back to the OR to take the stent removal, or I got used to every now and then got a big diplopia. If you're a fan of Hamid's, then you got used to your cysts, but it needs to use to the complications that we know tubes have. So we basically don't like our choices. I mean, we're voting between the lion or the wolf. And this is why new devices keep coming in. This was a paper from 3 years ago where Merhmou described a technique that was actually very appealing, and it got us started. So the concept is, instead of putting a 300 microtube inside the anterior chamber, let's put a XEN in the middle of the sclera as a bypass. So as a flow restrictor, to make sure that we don't have to use a stent on the Barvold. That way we could use the plate of the Barvold, but inside the eye, we would use the safe part of having a XEN. So that way we don't have hypotony because the XEN will flow restrict, and we have a very big plate. So this is a surgery from us. Basically, we've already implanted the tube. This is a patient with an area that got a phakic had an IOL with a fake iris, so iris prosthesis, and you just put the XEN ab externo, basically, and then actually I'm just moving it forward because, and then finally you just have to cut the Barvolds, and then you place one over the other or inside the other. This actually goes very well. This is actually done by a resident of mine. She's a very good hands with this, and actually it's a perfect fit. And you just leave it like that. This is how it looks in the end, and you just suture it, and that's done. So it's not very complex in the so to speak. And these were the results we have. We compared it to the Hamid's because most of them, with the comparison to make it wide, because we only had 12 or 15 cases where we thought this would be a good candidate. And our comparison, if you're using a Hamid, this does not overperform the Hamid's. This also got recently published on ACTA, actually 2 months ago. And actually, there's no big difference to the Hamid's if you're using a Hamid's. The advantage is, inside, there's theoretically much lower chance of having a corneal decompensation. Of course, when you're operating a 75-year-old, that's not a big concern. But if you're putting this on kids, which have 60 or 70 years to live, then this becomes attractive. And this is why the centers that have adhered to this were the ones doing congenital glaucoma, because then you're worried about that endothelia not for 5 to 10 years, but for 50 or 60. So these new technique, the big problem is actually you have to put the costs into this, and it costs 1 XEN more, which is not exactly cheap. And the efficiency rate does not overperform what you already have. It's just apparently it's safer than what the others are. This is why there's still room for improvements, which is, I mean, over here, you're talking about lumens of the tubes that you put in your eye. The left part is the hammets and the barvolds, which are extremely high. And then you have the very, very low from the eye stents or the in focus. And you could see that there's a big gap over there. So we're probably going from the very, very large tube to the very small ones. And maybe there's something there. Pole tubes try to address this. This has the same plate and size as the barvolds. It's a non-valved. The similarities to the hammet is actually, it's much more flexible. We can discuss whether or not this is easier to place or not. But the very thin lumen, actually from Poiseuille's law, makes it much more difficult to cause hypotony. The surgical technique is basically the same as you would do it with a barvol, with the difference is that you don't have to put a stent. So this actually is much clearer. So you would think that the material, the silicone material, will be as a hammet, but it's not. It's a pole, but it's much larger than the hammet in the 350, like a barvol, so a hybrid, so to speak. And then you place it in with a 25 G needle entry. You suture it down, and then you just put 2 vicryl sutures. So this is aqueous humor pouring out, and you just titrate it to see whether or not it comes in, and you close it in with 2 vicryls, flow for titration, and then you close it until it stops. And then they recommend to do a tuto patch as an interface between the plate and the tenon to make sure that at least in the short term it doesn't collapse. And then you cover the rest of tuto patch, you put some glue, and this can take the procedure down to less than 1 hour. So it doesn't take much more time. Cost-wise, it's cheaper than the barvolds then, and early results from clinical impression is that it works actually, apparently short-term at least, with very good results. Professor Stallmans were referring to some works we've been doing, and we're actually doing MRIs in our department to every tube we can do. And we're actually comparing the poles, the hammets, the barvolds, and now the New World Medical clear paths. And I just wanted to show you 2 or 3 things before I finish. This is a patient that got a pole on this eye and got a hammet on on the left one. And this, you could see that the plate, it's this black arrow over here, and you could see a huge bleb forming, actually so huge, actually the eye itself becomes flattened over there. And you compare it with a very short bleb that you have over here. You could have the hammet one, which has a very low plate, and you can actually see that the stria, the fascia that unites the 2 muscles, was actually the one thing forcing these hammets not to inflate. So we actually probably need to learn a lot more about orbital anatomy to understand why or not things are allowed to inflate the bleb or not. We're doing this basically and you will see this is a pole on this side, and the size of the bleb is so big that it goes behind the macula. So sometimes our patients that complain about, I don't have a very good eyesight after the surgery, and you look at the eye, it's perfectly normal. You just have an astigmatism, and you think, this is probably from the cornea. And probably if you do a macular OCT, you would have to think that probably that macula is being pushed from the back because of that bleb. So probably you're a better surgeon than you consider yourself, and you can't blame it. It's something part of normal anatomy. So we're using 3D reconstructions to make sure if there is any plate device that is allowed to touch or not the optic nerve, which is the safest that doesn't move away. And so we're exploring these situations and analysis. So ultimately, I'm missing Ronaldo here. We're switching between an efficient and experienced football player or technique with a solid reputation. Maybe not as friendly as the audience would like. Maybe the best days are already behind him. There are new players coming in with brilliant novel tricks, but their careers are still too short. but the future does look bright for them. Thank you.
Thank you, Professor Pinto, for this comprehensive. Hello, do you hear me?
Yes.
Yeah, this is a very nice presentation and comprehensive, and really it is an updated one. And we have a couple of questions. Do you use UCP after glaucoma drainage devices? So if a
Yes.
patient have glaucoma drainage, do you start him treatment with UCP?
Yes, I've had to do it a couple of times, but basically I didn't find it a difficulty. I know that because of the bulge it causes in the orbit, it might be difficult to place the cone to make sure that the eye itself is stuck with a vacuum. But application-wise, I didn't find it any difference, not on the OR nor an efficacy rate. The other way around, it's not the same, because if you do cyclodestruction first and then you put a tube, there are the very likely chance that you will get a hypotony on the early days, especially if you're using a non-valved. But the other way around, as you said, I didn't find a difference. So it's feasible. It can be done with no particular complication, I think.
So the number of Zens you have put in your glaucoma career, how many?
My department has put around 200 of them. I tried to put other people to do the exams for me. This is a complex situation, which I basically give the indications. I trained them. So all those residents that you've seen were trained by me. And so myself, I would say I probably did the first 100, and then I asked my residents and my colleagues to help me with them.
Okay. Is there any rule for UCP in congenital glaucoma?
I don't have very strong feelings about that. The reason is the cornea diameter, and this is something that I already asked ECE, I take care. I mean, they don't have larger than 13 probes. So congenital glaucomas have corneas of 13, 14, 15. And so they simply don't have a cone for that. And there's not a market. So first of all, I don't think it's actually feasible to start with. So you'd have to find a congenital glaucoma with the narrow cornea diameter, which is not easy. That being said, it can be unpredictable on kids, as with any cyclodestruction surgery. So most likely, and we've done cyclodestructions and then putting tubes, it will cause hypotony every now and then. So I would not be a fan.
Okay. And in patients who are aniridia, patients with aniridia, do you use UCP for treating their glaucoma?
It's not that much common over here. I have a couple of patients. I've done it on one. Yeah, I ended up having to do a tube, but it was only like 2 years after. So it depends on whether or not what you're aiming at. Because you have to remember that the UCP will either drop you 30% or will allow you to decrease the number of drops, but most likely will not do both. So it will depend on what your conversation. Most of these patients are very young, and so their target is low. And so if they can keep their drops and they don't mind keeping their drops, UCP is an option. If you want to give them a low target drop-free option, then an iridia would not again be the best situation, I think.
Yes. Also, how many times you can repeat the UCP, and what is the time interval between each one?
I've repeated in a couple of patients, not that many. It can be repeated. There are publications with more than 3 times actually repeated UCPs. You have to consider that first they need to be responders, and you have to think that if they fail, you have to give them enough time to go back. So the ones I actually had to do it again, I waited at least 4 months. I'm not sure if any other users do it differently.
Yeah, Dr. Stallman, do you have an experience with the repeating the UCP or patient with glaucoma?
I don't routinely repeat UCP. I do it in selected patients where I feel that the effect was significant from the first treatment and the effect lasted long enough. So at least 6 months, preferentially 1 year. If then the pressure goes up a bit, then I think it's a retreatment is can be considered. But in my population, it is a minority.
Okay. Also, there is a question from Dr. Ghadir from United States of America. Ghadir, really, she's our fellow in, she's training now in Dallas, Texas. Do you put ligature suture on the Barville Zen tube?
No. Actually, that's the advantage of putting the Barville Xen, is that the Xen will act itself as a flow restrictor. So you don't get below 6. That's the advantage. So you're, and especially on kids, where you have, if you place a stent, you're bound to have to take it away eventually. So it was very tempting to start to say, okay, we put a very nice thing inside the eye instead of a 300 microsilicon tube. And then we don't even have to go back again to the OR. That was the theoretical advantage. And that was why we only did 12, 15 cases, because basically with congenital cases.
Okay.
The reason we stopped not doing to adults, for instance, or 30s or 40s, is that sometimes, and this is something you see with Xens every now and then, they block. With a normal Xen, you do a needling or you replace the Xen. Having to replace the Xen on a congenital case over here involves you opening up the conjunctiva again. And 1 year might be very good for an 80-year-old, but 1 year in the congenital glaucoma, it's a blink of an eye. So it's not as predictable, and that's the reason why we still do it every now and then. And it's a very theoretical, good solution. It needs just to be balanced over there.
Okay, so do you prefer put the Zen gel up interno or up externo? And do you prefer to use the gonio lens, or with experience you don't need the gonio lens to put the Zen gel?
I don't use the gonio lens. I've been trained not to use them, and so since I've learned from start without, so for me it was just simply not to use it. I put it ab interno, mostly actually with combined procedure. So at the end of the phaco, I place a Xen. And then basically your question was the gonio. That was the reason why we did that study, because what the gonio people say is that, oh, I know for sure where I'm placing it. And the discussion was, is that knowledge worth having? I mean, what should I waste 5 minutes of my time and then feel miserable because I didn't reach what I wanted? Would that affect the patients other than my ego? And apparently the patient is fine.
Great. Also, there is another question. What is the main complication of the use of UCP? I think you answered this. Thank you, Dr. Bento, for this nice presentation. And now we will move to Dr. Stallmans. Dr. Stallmans is a well-known ophthalmologist in Europe and all over the world. And she is the head of the Laboratory of Ophthalmology in Catholic University at Leuven in Belgium, as the glaucoma unit of University Hospital also in Leuven. Dr. Stallmans was a guest here in Jordan for 2 years, and we were very happy to host her in Jordan, and we did great surgery with her, and she is a great mentor to me. Please, Dr. Ingeborg, the mic is yours.
Thank you very much, Dr. Abdul, for your kind introduction and for inviting me to participate in this interesting symposium. So my contribution today will to talk about one of the novel surgeries, which is PreserFlow microshunt. This is the overview again of the currently available glaucoma surgeries, and the microshunt is situated here. So it is an up external procedure that leads to subconjunctival drainage. So it is a blood-related surgery. Here you see the implant. So the tube diameter, the external diameter is 350 micrometers. So it allows a minimally invasive incision tract. The length is 8.5 millimeters. And it has an inner lumen of 70 microns. And these dimensions have been carefully designed to balance, to actually prevent blockage and hypotony and allow a controlled IOP reduction. The distal end is 3 millimeters long, so it goes quite posteriorly. And there the aim is to create a posterior bled away from the limbus. And it has a little wing in the middle, as you can see, which prevents migration and also leakage around the tube. And it also orients the device, because the device tip is beveled and is supposed to be implanted bevel up. It has no plate, which makes the surgery less traumatic. This is just an overview of a number of devices to give you a perspective of their dimensions. You see that the microshunt is 70 microns. If you compare that to Xen, for instance, it's 45, iStent 120. Most of the long tubes are 300, with the exception of the Paul tube, as Professor Pinto explained, has a smaller lumen of 120 microns. Then the materials. It is called SIPS. It is soft and flexible, so it takes the curvature of the eye. It is biostable and very compatible. So it has no degradable bonds, which is important because degradation induces inflammation and therefore fibrosis. So the idea is that this is very stable and therefore induces less fibrosis. It has been used in the human body already as a cardiac stent, so it has been implanted in millions of patients and has not caused any safety issues. And of note, the material is non-animal, so there is no issues in that sense. And just a detail, the material is MRI safe, so no problem with that. The microshunt comes with a kit, and the kit contains, of course, the implant, but also some tools that you use during implantation, so a scleral marker, a knife, a needle, LASIK shields, and a marker pen. Besides that, you need some extra materials, but which are really very common instruments which you also use for other glaucoma surgeries. We like to place the implants either supratemporally or supranasally. We usually avoid the 12 o'clock position because the implant goes quite posteriorly and you make a very deep pocket, so you could encounter the muscle there, which we try to avoid. So here you see an implantation video. So you see that I open up the conjunctiva first at the limbus. The incision is a bit smaller than for trabeculectomy. Then I open up the tenons. I like to open them separately, and the tenons plays an important role here. So you see I dissect it carefully and separately from the conjunctiva. Then I make a very wide and deep pocket to give good flow. Then I do some coagulation, wet cautery. I do this very gently because I want to have a wide sclera, but without burning the sclera, again, to avoid fibrosis. Then I apply mitomycin C. So first I grasp the conjunctiva with a forceps, which allows me to evert the edges of the conjunctiva to avoid mitomycin exposure. You see I place the LASIK shields, which are thin but have a large surface, so to be able to actually treat a large surface with mitomycin C. And then I typically use a concentration of 0.2 milligrams per ml, and I apply it for 2 minutes. Then I take them out and I rinse roughly. That's actually exactly the same as I do for trabeculectomy. And then we start the actual implantation. So I mark the sclera at 3 millimeters from the limbus. Then I take the knife, which is it has a width of 1 millimeter. I go in at 3 millimeters, make a superficial incision, and I go until the sharp edge of the knife is in, and then I pull back. Then I take the needle, which is provided in the kit. It's a 25 gauge needle, an orange one. I bevel it, I go into the pre-made tunnel. When I reach the end of the tunnel, I tilt the needle a bit, and then I push forward to enter the anterior chamber. I try to enter the anterior chamber parallel to the iris, to have the implant also parallel to the iris and not too close to the endothelium. And then I take the device with an atraumatic forceps, and I simply slide it into the anterior chamber, and you see the wing there, and the wing will actually end up in the pocket that I've created with the knife, and will serve as a cork to the bottle, so to speak. So it avoids leakage around the implant. So this is how the implant sits. So it has 3 millimeters to the back, and here you see the intracameral part. Then we check the flow. So I just lift it a bit with the scleral marker, and then I check the flow, and you see that it drips gradually. Once I've checked the flow, then I'm going to close the conjunctiva and the tenons, and I'm just showing this video, which is speeded up a bit, to show that I carefully suture not only the conjunctiva, but also the tenons, to ensure that the tenons is pulled forward and is stretched, to avoid that the tenons blocks the ostium of the implant in the end. So you see it's nicely pulled forwards with 2 purse strings. Sometimes I place 1 mattress suture in the middle as well. Some results. So these are actually clinical trials that have been performed or are ongoing, and of course the most famous is the US trial, where it's a randomized trial comparing microshunt to trabeculectomy, and there is some publications that are already out there. You see that the results actually show pressures after 2 and 3 years that are around, after 1 year, around 13 and a half. There is one study that showed even pressures between 10 and 11 after 3 years. These are our own preliminary data. We use the device since about a year now. And you can see that I've just put together the numbers here. The baseline IOP, preoperative IOP was 21.6. And then you see the pressures after day 1, week 1, month 1, month 3, month 6, month 9, month 12. I wouldn't look too much at it yet because we only have 3 patients at this point that had reached the 12-month time point. But you see that we indeed, comparable to the publications, the pressure, we reach pressures of around 13. This is another way of looking at the efficacy. So the percentage of eyes that achieve a certain target pressure. The blue bars show you the pressures below 18, and you see at month 9, 87% of patients had reached pressures below 18. Of course, if you aim at even lower target pressures, then the numbers go down. So below 13, much more challenging, but still 65% of patients actually reached this target pressure after 9 months. And the number of drops, preoperatively, a mean number of drops of 2.8, and at month 9, the average was 0.3 drops. So these are the preliminary results that my resident Nawid Faizi is putting together, and obviously I hope to come with some more data soon. But this is just to give you first idea of what to expect from this novel device. I thank you very much for your attention. I'll be happy to take some questions after this lecture.
Thank you, Dr. Stalmans, for this nice presentation. And do you think it is a good option for a neovascular glaucoma?
It depends on what stage of neovascular glaucoma. I must say that my preferred option for neovascular glaucoma in the acute stage is actually a diode and anti-VEGF. In the more chronic stage where you have synechiae and so on, I usually choose long tubes because of the synechiae and the higher chance of bleeding and fibrosis, and trabeculectomy tends to have a high failure rate. Microshunt you might consider in the patients that have an open angle, but obviously you need an open angle, and you know, in neovascular glaucoma, often the angle is full of synechiae. So in those patients, in severe neovascular glaucoma patients with synechiae, actually I do prefer the tubes, and I tend to place them, if possible, in the sulcus because of the synechiae.
Okay. We have also a question from... Yes,
yeah,
go ahead, Dr. Ahmed.
I think Dr. Stalmans heard it many times, but Zen or this device in focus or preserve flow, especially if you are putting them ab externo. So
your question is, how do they compare? Or sorry, I missed it.
Yeah. Which one do you prefer with your experience?
Okay, that it depends on the patient. I think both have their place. If the target pressure is not very low and you want to be really minimally invasive, for instance, also in elderly patients that have a thin conjunctiva and not much tenons, those are the ideal ones in my view for Xen, because in my experience they work best in the patients with less tenons and thinner conjunctivas. If I need lower target pressures and if they have a thicker tenons, if they had some previous surgery, for instance, I will rather go to a microshunt. And then if they need very low target pressures, like in normal tension glaucoma, like target pressure of 12 or below, I would rather go to trabeculectomy. So that's and then in the very challenging cases with previous vitrectomies and multiple surgeries and so on, then it's more towards the long tubes, obviously. So that's how I position a little bit the different devices in my population.
Thank you.
Okay, there is another question from Sakhar Hamid. Go ahead, Dr. Sakhar. Dr. Sakhar? Hello?
Hello?
Dr. Sakhar, do you hear me? Okay, there is another question. Is it comparable to trabeculectomy in the rate of complication?
I have the impression that the efficacy seems to be quite similar to trabeculectomy. Maybe with trabeculectomy I can get even lower pressures. So you can trabeculectomy you can titrate towards really low pressures if you wish. So then if I in a normal tension glaucoma patient where I have a target pressure of 10, I will make a thin scleral flap. I will make my sutures a bit more loose and so on and so on. With the microshunt, it is more consistent. You don't make a flap, so you don't put sutures, so it's a very consistent result. With nice pressures, average of 13, which is really nice, but not the really low ones. In terms of complications, with a microshunt, I must say that they're quite consistent. Day one, they typically have a pressure of 6 or below, asymptomatic. I rarely see symptomatic hypotonies with the microshunt, similar to XEN, whereas with trabeculectomy, you get more surprises. So I find the post-operative course more relaxed, less stressful. Of course, with the trabeculectomy, you can, if you want, adjust in the first weeks. But yeah, so until now, I must say that I've been very satisfied with the post-operative course of microshunt, similar to XEN. The difference, I think, between XEN and microshunt in the post-op phase, in the early post-op phase, I feel it's quite similar. In longer beyond, I do have the feeling that I get significantly less needling rates with the microshunt and with the XEN. So they tend to scar less frequently in my experience. However, if they scar aggressively. So I feel that needling in microshunt is less effective than in XEN. So if XEN fails, I will rather do, if I see the implant well, I will do a needling. If there is a lot of scar, I will do a revision. If a microshunt fails, I will rarely do a needling. I would rather do a revision, open them up, remove the scar, and close again. And that's very effective.
Okay, the concentration of mitomycin and the duration, how much?
I use 0.2 milligrams per ml for 2 minutes in the microshunt. But I always advise, use whatever works for you in your trabeculectomies, because obviously the concentration of mitomycin that you need in your patient depends on your patient population. So I would just advise to use the same concentration and duration than you do in your trabeculectomies. So
you will find a blip after surgery, right? It's not a blipless surgery. Yeah, no. Like trabeculectomy.
Absolutely. Yeah, maybe a bit more posterior though. With trabeculectomy, you have a bleb closer to the limbus. With the microshunt, often you see when you look at the limbus, you think, oh, there is little bleb formation. But then when you make the patient look down more, then you see a big posterior bleb, which is nice because you don't see those limbal, very thin cysts that you sometimes see after trabeculectomy with mitomycin C, and that can start leaking as well. I haven't seen that yet in a microshunt.
Okay. There is also a question from Ali Al-Sheikh. Do you find it is more safe if you put one suture around the distal end to avoid elevation over the scleral surface and avoid protrusion?
I have had that concern initially, and I was very tempted to place sutures, but my surgical trainer said, no, don't do it. It's not necessary. And they were actually concerned if you put suture that you would induce some inflammation and therefore fibrosis. So that's why they recommended against. So I don't place them. And I must say, I have had one implant that eroded through the conjunctiva, and that was actually my mistake. It was one of my very first implantations where there was some, the tenons was lying over the end of the ostium of the implant, and I thought, oh, I will remove the tenons, then it has less resistance. So I cut out the tenons, which is not what you should do, because if you have only conjunctiva over the implant, that's when you can get an erosion. So that's why I stressed during the videos that I carefully suture the tenons. I pull it forward and I suture it forward to have it stretched over the implant and stretched so it doesn't block the ostium.
Okay, great. Any question from the panelists? If you have anything to ask Dr. Stelmans before we move to our last speaker.
Thank you very much.
Okay, thank you. And now our last but not least speaker, Dr. Arif from University of Illinois in Chicago. Dr. Ahmad is a professor of ophthalmology and vice chair for clinical affairs and the glaucoma services. and he is the Director of Residency and Glaucoma Fellowship in the university. Dr. Ahmed, we are very happy to host you, and please, the mic is yours.
Thank you very much, Dr. Muhammad, and thank you for putting this together. I think this is wonderful, you know, getting together specialists from all over the world. I've really learned a lot so far. I think I just need permission to share my screen.
Dr. Stallman, can you close your screen?
Yes, I've stopped it. I'm sorry about that.
Okay. Okay, Dr. Arif.
Okay, thank you. So I've really enjoyed the talk so far, and I'll be talking about two devices that I use in my clinical practice, the Cahook dual blade and the iStent inject. These are my disclosures here. Importantly, I am a consultant for New World Medical, which does manufacture the Cahook dual blade. And I wanted to start with basically just a general framework for how I think about glaucoma surgery in very broad terms, with so many options now that have become available and so many options that are in the pipeline. The first thing that I think to myself is, what stage of glaucoma are we dealing with? Are we dealing with early or moderate glaucoma or more severe glaucoma? And I think of a dotted line between those two categories, mild, moderate versus severe. And it's dotted because I think that we can be flexible with some of the devices and interventions that we have. And certainly MIGS devices that we typically think of using in mild to moderate disease, we can certainly cross over in some cases and use in severe disease, and vice versa. If it's early or moderate disease, I then think, am I dealing with primary open-angle glaucoma, or am I dealing with secondary open-angle glaucoma? And if it's primary open-angle glaucoma, particularly in the setting of a cataract, well, then I'm more likely to consider a stenting operation, such as the Hydrus stent or the iStent inject. If it's secondary open-angle glaucoma, particularly pseudoexfoliative glaucoma, then I'm very likely to consider the Cahook dual blade excisional goniotomy, or something like the GATT procedure, where you're excising the inner wall of trabecular meshwork in Schlemm's canal. If we're dealing with more severe disease, then I'm more likely to consider filtration surgery. And if we're considering filtration surgery, I will then assess the risk for subconjunctival fibrosis based on the patient's age, ethnicity, prior surgical history. And if that risk is low, then we may consider something like the Zen implant or the PreserFlow, now that I do not have experience with, or with our gold standard trabeculectomy surgery. But if we deem that risk to be high, then we're more likely to consider aqueous shunt implantation. I think every glaucoma surgeon deserves a wildcard procedure. And for me, that wildcard procedure is endolaser cyclophotocoagulation. I use this procedure frequently, and it really crosses all disease stages and all glaucoma subtypes. And it has really helped me a lot in terms of difficult cases to manage. So these are just a general framework that I use to think about glaucoma surgery. When thinking about MIGS surgery, of course, visualization is really key. I also work with many trainees, many residents and glaucoma fellows, and those trainees have to prove to me that they're able to intraoperatively view the anterior segment structures properly before being allowed to intervene with any MIGS procedure. It really, once you've gotten the visualization part of the procedure down, the rest of it really flows from there. And so the operating microscope is tilted 45 degrees towards the operating surgeon, and the patient's head is tilted approximately 45 degrees away. If you ask me what my go-to MIGS procedure is today, I would have to say that it's the Cahook dual blade. This is a MIGS device that I use most frequently. Almost every week we do this procedure. And there are many reasons. You know, the blade was designed specifically for removal of the trabecular meshwork with minimal damage of the collateral tissues. There's no hardware that's left behind in the eye for any risk of dislodgement or any issue later on over the patient's lifetime. It was engineered specifically for the anatomy of the trabecular meshwork and canal of Schlemm. can be performed through a clear corneal incision and can be done in conjunction with cataract surgery or as a standalone procedure. And really, in terms of the finances, at least in the United States, it does not make a difference whether this is performed in combination with cataract surgery or as a standalone procedure. There are some features of the Cahook blade that are very unique to other devices that may be used when performing goniotomy. The tip of the device is pointed and sharp, and so allows for easy piercing of the trabecular meshwork. And then the ramp, which lies posterior to that tip, puts the tissues on stretch. And on either side of that ramp are the two dual blades that once the tissue is put on stretch, very easily allow for cutting and excision of the tissue. The foot plate of the device is dull, and once it's rested back posteriorly, allows for minimal damage of anterior segment structures as the procedure is being performed. It's really that ramp portion of the device that is critical. Because the tissues are cut and put on stretch and elevated, that's what allows for easy cutting. And I think for those of you that do the Cahook dual blade procedure or are interested in it, that once you've entered the canal of Schlemm and rested the heel of the device back, the device just glides along within the canal very, very easily. And that's because of the ramp portion of the device that puts the tissues on stretch. Here you can see histologic studies in cadaver eyes that have been treated with goniotomy using the MVR blade, the trabectome, and the Cahook dual blade. You can see with the MVR blade, you get some damage to collateral tissues, the underlying sclera, and you also get to have some residual trabecular leaflets, which can act to scar over and limit the long-term efficacy of the procedure. With trabectome procedure, there's a little bit less damage to collateral tissues, but there's still residual trabecular leaflets that may then heal and limit long-term efficacy. And if you compare that with the Cahook dual blade, you get a very clean excision of tissues with very little in terms of residual trabecular leaflets and very little in terms of damage to collateral structures. I was fortunate to be part of the pilot group of surgeons that looked at use of the Cahook dual blade. We performed the first prospective multi-center case series with the device in consecutive cases. We looked at intraocular pressure and medication usage outcomes, complications, and we also performed a qualitative user survey. So we looked at 122 eyes among 8 surgeons, and not surprisingly, the most common glaucoma subtype that was treated was primary open-angle glaucoma. But somewhat surprisingly, especially when considering this as a MIGS procedure, you could see that there was a wide variety of glaucoma stages. In fact, 41% of patients in this study had a severe stage of glaucoma. Here you can see our intraocular pressure and medication usage results, and note that the baseline intraocular pressure started out at a mean of 17 millimeters mercury, so lower than what we are accustomed to with surgical glaucoma trials, but I think representative of the types of patients that we deal with who require surgical intervention. Often we are successful in reducing their intraocular pressure to a point medically, and then after that something surgical is warranted. In spite of that relatively low baseline intraocular pressure, we were able to achieve incremental lowering of approximately 5 millimeters mercury, and that's when Cahook dual blade was combined with phacoemulsification surgery. We were also on average able to reduce the medication load by at least 1 medicine. In terms of complication profile, far and away the most common complication is going to be a hyphema. I would say 100% of the time you see at least a microhyphema, which is actually a good sign. It tells you that you've removed the layer of resistance between the anterior chamber and the episcleral vasculature. It is important to note, though, that the presence of hyphema will lengthen the recovery time after a procedure when combined with cataract surgery. And so you do need to prepare the patient for that because the recovery time in terms of visual restoration will take longer when cataract surgery is combined with Cahook blade. And that may not be the case with other mixed procedures such as the eye stent. So I wanted to show two cases. Both of these cases I did last week, and I wanted to show them for different reasons. You know, the first case that I'll show here goes relatively smoothly, and the second case does not. So here, we've made our corneal incisions. I've gone now to performing the Cahook blade procedure before I do the cataract portion of the operation. We're entering with the Cahook blade at about a 15-degree angle. Here we've visualized the trabecular meshwork and the anterior segment structures. We want to come in at about a 15-degree angle to allow for engagement of that pointed tip within the canal. We're getting ready to enter, and as the pointed tip slowly enters the canal, and then once we enter, we rest the heel of the device back. Once we're at this point, really, as I mentioned, the device just glides along the canal, and there's very little in terms of resistance. You don't want to see too much movement of the globe, which may indicate that you're too deep. And you love to see that beautiful white stripe trailing behind you as you treat, exposing the back wall of Schlemm's canal, telling you that you've succeeded in removing the inner wall of Schlemm's canal and trabecular meshwork. So that was the first case that I did last week. The very next patient is shown here. Now this patient, we had some trouble because the patient kept falling asleep during the surgery and would keep waking up every 5 minutes, startled, and would move suddenly. So we went ahead, we visualized the same way with direct gonioscopy, get started here with the procedure. Initially, I think maybe we were a little too superficial. We get started with treating in the other direction, and you'll see we're getting some patient movement here as he's starting to wake up during the procedure. So we go ahead and try to calm the patient down, remind the patient that they're in surgery, remove the Cahook dual blade from the anterior chamber. Here you can see some reflux bleeding. We go ahead and fill the anterior chamber with viscoelastic to tamponade that bleeding. Restore our view, and because I felt like we were a little too superficial, I felt like we should go ahead and continue treatment. The patient is now awake, and here I think we've entered a little bit more properly, and here you can better visualize that white stripe trailing behind, and I think that portion of the procedure we were more effective in our treatment. And so one thing I've noticed with the Cahook dual blade is that it's a very forgiving procedure in cases like this. One can go back if they're not satisfied initially and retreat right then and there. And the same cannot be said, I think, for some of the other MIGS procedures that involve placement of an implant. It can be very difficult, what I've found in my experience, to go back and retreat if we're not successful initially. These are photographs of that trabecular cleft that we love to see postoperatively on gonioscopy. These were courtesy of a friend of mine, Leo Siebold, at the University of Colorado. I wanted to show a few cases that illustrate the utility of the Cahook dual blade in my practice. Excuse me. Cases that you wouldn't necessarily think of a MIGS procedure as being useful. So the first is a 14-year-old Hispanic male with juvenile onset glaucoma. He has 20/20 vision in his right eye, but has unfortunately lost most of the vision in the left eye. He's undergone Beervelt glaucoma implant in his right eye. He then underwent micropulse laser cyclophotocoagulation. And despite those measures, intraocular pressure remained in the high 20s. We decided to go ahead with the Cahook dual blade after the patient had undergone Beervelt implant, after the patient had undergone micropulse laser cyclophotocoagulation, and that allowed us to get the eye pressure down to the mid-teens for a 2-year time period. Next is a patient with advanced glaucoma, 53-year-old African-American male, again, functionally monocular with no light perception vision in his left eye. These visual fields are fields from his better seeing eye. He's previously undergone trabeculectomy surgery with one of my partners. I then put in an inferior Beervelt implant a few years later. His intraocular pressure had been doing great while being maintained on 2 medicines for many years. But then the patient underwent a steroid injection into his knee. And that shot up his intraocular pressure into the 30s. And even though we maximized medical treatment, his intraocular pressure did remain uncontrolled. We knew we had to do something in this patient with advanced disease that was monocular. I didn't want to put the patient through another Behrveld shunt, knowing that the effect from the steroid would likely be temporary. So I thought this patient would be a good candidate for the Cahook blade, which we performed, and the patient maintained good intraocular pressure afterwards, and the effect from the steroid then was over with, and he remained controlled. Lastly, was a patient with pseudo-exfoliative glaucoma who had undergone an Ahmed glaucoma valve in his more advanced right eye. Intraocular pressure was still elevated. He was only tolerant to 2 topical medicines. We combined the Cahook dual blade with endolaser cyclophotocoagulation, and that allowed us to control intraocular pressure. And so the Cahook dual blade is versatile in that way as well, in that it can be combined with other procedures. We'll shift gears now to the iStent inject, which was FDA approved in the United States in June 2018. This is a reiteration of the original iStent. This allows for 2 of these titanium devices to be placed across the trabecular meshwork and inner wall of Schlemm's canal to act as a conduit between the anterior chamber and Schlemm's canal. This is a video courtesy of a friend of mine, Evan Laguros, who's in private practice in Illinois. Here, the device is placed within the clear corneal incision. The injector tip has a sleeve which can be retracted, exposing the device. Once you've positioned across the trabecular meshwork, there's then a button on the applicator that can be depressed in order to deploy the inject across the inner wall of Schlemm's canal and trabecular meshwork. You want to place these devices a few clock hours apart to maximize the efficacy of filtration across that inner wall and maximize chances for exposing a collector channel. So relatively straightforward procedure. You know, I think the difference between the iStent inject and the Cahook dual blade intraoperatively is there's much less bleeding with the iStent. And so the patient's recovery from vision, especially when combined with cataract surgery, really the recovery time is not much different, and the postoperative course is not much different when compared to standalone cataract surgery. So that is one advantage of the iStent. When looking at MIGS procedures that were investigated in the FDA registration trials, 2 outcomes were looked at: the percentage of subjects that achieved greater than a 20% reduction in their intraocular pressure unmedicated. So the beauty of these FDA trials is they took patients, they enrolled them, they washed them out of their medications so that you could see what their intraocular pressure was, naive of medications. They were then treated with the MIGS procedures in combination with cataract surgery, and then after 2 years, patients again underwent a washout so that you could judge the pure effect of the MIGS procedure in combination with cataract surgery. The second outcome was the absolute intraocular pressure reduction. And so the exact same methods were undertaken in all of these registration trials: the iStent inject, the CyPass, and the Hydrus. And you can see that all compare, you know, very favorably and similarly, with approximately 70% of patients that undergo these procedures achieve greater than 20% reduction from baseline intraocular pressures. Note, though, that in the comparison group that underwent cataract surgery alone, that those patients also had a beneficial impact from the procedure, just not quite as much as when combined with a MIGS procedure. And that translated to about 7 millimeters mercury reduction from baseline for each of these procedures, including the iStent inject. More and more now, we're going to start to have head-to-head trials that compare the various MIGS procedures. This was a head-to-head trial that retrospectively compared outcomes of cataract surgery in combination with Cahook blade versus cataract surgery in combination with iStent. And you can see that the results, at least just out to 6 months, showed that the 2 procedures were very similar in terms of absolute intraocular pressure reduction. Thank you very much for your attention. Again, thank you for allowing me to participate in this symposium.
Thank you, Dr. Ahmed, for the great presentation. And there are a couple of questions. Which gonio lens do you use for Kahuku blade?
I use the modified Swan Jacobs lens. I would really, I'm trying to negotiate with our hospital to purchase the Vold lens, which has a fixation tool to allow for better fixation and better mobility of the globe. That makes a lot of sense to me. And I think it'll be a lot easier, especially, and probably shorten the learning curve. So hopefully I'll be allowed to use that lens soon, but for now I just use a modified Swan Jacobs lens, which allows for easy entry into that corneal incision.
The other question, can Kahuku blade be used more than once for the same patient?
I have not yet done that with the Kahook dual blade. The answer to that question would best come from studies that have looked at repeat trabectome. You know, the trabectome was an electrocautery system that allowed for electrocautery of the inner wall of Schlemm's canal and trabecular meshwork in a manner very similar to the Kahook dual blade. And there are some studies that looked at repeat trabectome, and you can get some incremental efficacy when doing that, but usually it's short-lived. And for that reason, I don't usually repeat the Kahook blade, and I'll go on to a different surgical option if it hasn't worked at that point.
Okay, so do you prefer Kahook blade goniotomy first or phaco?
That's so when combining cataract surgery with Kahook dual blade, the way that I had done it for years was to do the cataract surgery first before doing the Kahook blade, so that minimizes any risk to lenticular damage, and to know that the cataract surgery has gone smoothly, and then to allow for pharmacologic pupillary dilation before proceeding to the Kahook blade. Just recently, over the past month or so, I've gone to doing the Kahook dual blade first, and I've actually liked that a little bit better. I think the visualization is a little bit better in terms of the cornea, and often you do not need to pharmacologically constrict the pupil to access the anterior segment and trabecular meshwork structures. And so that's what I've experimented with for the last few weeks, and everything is a little bit more stable too in terms of viscoelastic retention in the anterior chamber when being done that way. And so I've just recently converted to doing the Kahook blade first.
Okay, so your incision is temporal and you did the Kahook blade nasal, right?
That's correct, yeah.
Okay. So, and you do stitches for your wound? You would stitch or hydration of the wound only?
Yeah, I'm a very conservative in that regard. It takes me just a couple minutes to suture the incision. Thankfully, I have not seen cases of hypotony with the Kahook blade, but I do put one suture through the corneal wound in combination with Kahook blade. Many surgeons do not and have been okay.
Okay, there's also another question from Dr. Ali Al-Sheikh. Are you always remove the Schlemm canal strip after cutting with the Kahook dual blade, or you keep it in the anterior chamber?
Initially, when we first started to do the procedure, we were very obsessed about trying to remove that strip of trabecular meshwork before proceeding with remaining parts of the surgery. But now what we've done is just kept it in there, and you can use just irrigating aspiration tip to vacuum out the tip, the remaining trabecular meshwork leaflets without any issue. So I don't make a conscious effort to go back and remove it anymore.
Yeah, what type of viscoelastic you use in Kahook dual blade?
I use a dispersive viscoelastic because that allows for greater retention within the anterior chamber and greater anterior chamber stability. A cohesive viscoelastic more easily exits the wound as one is performing the procedure. And what I found when I use a cohesive viscoelastic is that the anterior chamber can shallow and start to obscure your view if you lose that viscoelastic from the wound. So I use a dispersive.
Yeah, okay. Dr. Ahmed Jum'a, please unmute yourself and you can ask your question directly to Dr. Arif. Do you hear me, Dr. Ahmed? Okay. I think by now we will end our session, and I want to give some thankful greeting from all the audience and the attendees. And really, I enjoyed it. And if it is more with 2 hours, I will keep watching because it's very fruitful presentation from all over the participant and from all over the panelists. And the last question and the final question, still, can we move beyond the gold standard, gold standard surgery in glaucoma? What do you think? I think the answer is yes. We can move from the gold standard to diamond standard, especially if we select the good patient in a safe ophthalmologist and in a safe hand of glaucoma surgeon like the panelists we have hosted today. Before we finish our night and say goodbye to everyone, I want to thank again API, Dr. Ala Aboud, Dr. Al-Atrash, and Layth Al-Momani, Dana Saoub. All of them, they did a great job to organize this scientific session. And Ala, if you have any something to say before we leaving.
Okay. Just I would like to thank all the panelists that attend our lecture today. On behalf of Amman Pharmaceutical Industries, Jordan, and wish you all the best, and thank you, and see you in the next webinars in the near future, inshallah.
Thank you very much. Thank you very much, dear friends and guests. Thank you, Dr. Arif, Dr. Stalmans, Dr. Ahmad, Dr. Ingeborg, and Dr. Lewis Pinto. And I hope that we will join again very soon after the finishing of this pandemic. And stay safe and